visiting surgeon from Komfo Teaching Hospital in Ghana, he is the inaugural colorectal fellow, fellowship trained colorectal surgeon in the country. And we, along with colleagues at the University of Michigan and University of Arkansas, have been helping put together this training program because there's a need to offer these kinds of surgical services to the population. And the Ghana College of Physicians and Surgeons expressly has worked with several of our institutions to say, hey, can you help us create this training program? Because our country needs this. How can we do that? How can we create that? And then can we use that as a model to create additional training programs in other specialties, in breast cancer and burn care and a variety of different things. So in many ways, Dr. Kwabena is sort of the tip of the spear of our collaboration, of our partnership. And so with that, I'm really excited to have him speak. Other key people I want you to know is Dr. Lian Huang, who's in the back, who's one of our colorectal surgeons here at the University of Utah in the Department of Surgery and Cancer Institute, and is the host for and the two of them worked together quite a bit over the course of the last year, and both here and in Ghana. So hopefully this talk will share a little bit about what the group is thinking and what they're working on for steps, what they'd like to work on for the next steps in their vision for the program. So with that, I will introduce.
I'm honored to be here today. It's my first time in the United States. Up to visit the city of Utah first. My initial appreciations will go to the Ghana College of Physicians and Surgeons for making it possible for me to have this training, and to the University of Utah and the Center for Global Surgery for such an immense collaboration. And to my mentor here, Dr. Lian Wang, for making it possible for me to be here. I hope by the end of this discussion and presentation, you will come to appreciate the challenges that we have regarding colorectal cancer management in Ghana, and also form some ideas in terms of collaboration, how to solve some of these challenges. This will be my approach to the discussion. I'll find a way to let you appreciate the burden of colorectal cancer in Ghana, and also appreciate some of the challenges that we can move forward from them. Just wanted to have an appreciation of where I'm coming from. I'm coming from Ghana, which is in the West African sub-region. We are the first country south of the Sahara to gain independence from the British in 1957. We have a population of about 30 million and counting. This is from the 2020 census that we had. Moving forward, there are two major teaching hospitals in the country, about 5 in total, about 2 major teaching hospitals, one in the capital, which is Accra, called the Kwabena Teaching Hospital. It's the premier hospital, the largest of all teaching hospitals. And my hospital follows, which is the Kwabena Teaching Hospital. This picture is to show you our accident and emergency center in Kwabena Teaching Hospital, having 10 years now since it was built. Kwabena is in the middle belt of the country and serves about 12 of the 16 regions of the country. It's mainly got a peculiar position and transport and linkage of roads and etc. So you can imagine that what I'm going to talk about, I'm going to go back to Kwabena to work. I'm currently training in Kwabena Teaching Hospital, which is in Accra. By the end of my training, which is just this coming June, I will go back to Kwabena to practice colorectal cancer management, and I'm going to deal with a lot of patients because 4 parts of the regions come to us. They refer us from all these places.
Use the mouse to do the down arrow, that might work.
There's something came to show so that
You can do this one.
okay. Just give you an idea about the background of what we are going to talk about. Worldwide, we know that colorectal cancer is the third most common cancer in the world, and annual incidence is in the range of 1.9 million people. Considering cancers that cause death is the second most common cause of cancer that shows how aggressive it is. The number of people who get cancers in a year, almost half of that population is going to die from the disease. Show that this cancer is very aggressive and needs to be focused upon. Actually, there are large disparity in this incidence and mortality rate across the world. To appreciate, I want to start from your own country to move on to sub-Saharan African countries. In the United States, recent studies just published this year showed that colorectal cancer is the third most common cancer in both men and women. But regarding mortality, is the third commonest cause of mortality and in men and the fourth in women. In terms of incidence, 36.5 per 100,000 population get colorectal cancer every year. Moving on to sub-Saharan Africa, which Ghana is part of, colorectal cancer is the fourth commonest cancer in the region, and is the second after prostate cancer in males, and the third after breast and cervical cancer in females. I have to realize that there's increasing reportage of high numbers of colorectal cancer coming to Africa. And it is projected and estimated that by the year 2030, colorectal cancer incidence is going to be as high as 85%. And by 2040, the incidence is going to double. So you can imagine that in the near future, Africa is going to have a high burden of colorectal cancer, more than in a high-income country like yourself, where the incidence is decreasing even now, stabilizing, even decreasing. And unfortunately, the rates of mortality is high in Africa. About 2/3 of those patients that present with colorectal cancer die from the disease. Moving on to my own country, in 1960, we said that one of our oldest professors showed that only about 4 cases of colorectal cancer was recorded a year. And currently, we are recording using one of our major cancer registries, only about 2 major cancer registries in Ghana, Kumasi Cancer Registry and Accra Cancer Registry. And most of our data, national data for cancers, come from the Kumasi Cancer Registry and report close to about 1,000 cases of colorectal cancer every year. And one of our professors who currently trained me, Prof. Dakubu, in 2010, did a research. It's hospital-based, though, but it gives you an idea that the reportage is far higher than what we really record. The hospital base has incidence rate of 11 per 100,000 population over a certain period up to 2010. And currently we are looking at the data to publish what the incidence is. But based on the Kumasi cancer data, we have colorectal cancer being the 9th common cancers and the 8th most common cause of cancer death. Now, regarding survival for colorectal cancer in Ghana, 5-year survival rate is only 16% of all the patients that come with colorectal cancer. If you want to compare for you to appreciate it, it's 65% in the United States. You can imagine that one of the major reasons that late presentation is a big deal. Yeah. Most of our cases, 70% present the third and stage 3 and stage 4 disease. If you are using the T-stage, T3 and T4, recent study done in 2018 showed that more close to 85% of patients present with T3 and T4 disease. It's quite that. Yeah. But interesting to note that currently our cancer cases are coming in the young people. It's actually also in the United States, but Africa is having increasing value of young people coming with colorectal cancer. And that is a big challenge and something for us to look at. Now, with this idea of what we are facing in terms of statistics, what are some of the challenges that my country faces with colorectal cancer. Now, there's a significant lack of screening, which I'll go into the details, delay in diagnosis, lack of diagnostic facilities, surgical skill and resources, as well as political facilities, and low research output. Now, if you consider that we are having increasing numbers of colorectal cancer in the nation, also consider that most of our cases are coming in late stage, then of course, it proves that we should go to focus more on screening so that we can catch them early. Unfortunately, that is not the situation on the ground. Though there's a national policy which was designed in 2012 regarding screening, the implementation is very low. The national policy talks about using the fecal occult blood test to screen Ghanaians above the age of 50. But we know that in the NCCN guideline now, the age is 45 years. For average rich people, it's 45 years. So that means that our policy needs to be reviewed pertaining to the current guideline. And the fact is that we are having more younger people. Recent studies have an average age of 50, around 53 as a peak age for most people presenting with colorectal cancer in Ghana. And I think that if you do another one, we're going to have them coming below 50 years. And therefore, we need to look at the screening and bring it down to 45 years. Fecal occult blood is feasible, but of course, it's a challenge to most Ghanaians. And average cost, with my research showed about 50 Ghana cedis around close to $4 to do a fecal occult blood in most places. But not all labs are able to do a simple test of fecal occult blood test. And you can only have it in the two major teaching hospitals, which is Kofanochi and Kolebu and other few private places. Unfortunately, the screening is not under our national health insurance. There's a national health insurance scheme which covers most of Ghanaians, which is government-owned, and also have the private health insurance. But the government health insurance, which most of us hook on to, doesn't cover screening, and therefore it's a big challenge, which we will look at solutions to that. The main diagnosis of, as you can see, as I said, 70% of our cases present in the stage 3 and stage 4 disease. What are these challenges? Social and cultural is a victim. Poverty is a major barrier to early diagnosis in our country. Affordability to healthcare is a big challenge. In terms of, I have patients that come in with suspect symptoms which make you suspect colorectal cancer. You request for investigations like colonoscopy, staging investigations like CT scan, and they might come in back after 6 or 1 year, and they have not done the required investigation. And it's interesting, sometimes with the request form that you give them, they keep it for as long as 6 months, 1 year, after bring the request form, but they have not done the requested investigation. You can imagine with cancer waiting 6 months, 1 year, what the stage is going to be, and all because of ability to afford. This is a challenge, a big ability to afford it. That's I always make the statement that in Ghana, sometimes we have patients dying not from the disease, but from poverty because they cannot afford investigation, so that they cannot afford treatment. Cancer drugs are not, colorectal cancer is not covered by the National Health Insurance Scheme. And therefore, chemotherapeutic agents, radiotherapy application, you need to pay for them. And already these people are poor. Average income is around $300 average income for most people. And how can they afford this? CT scan in my country costs about 1,005 Ghana cedi, which is close to $150. And if average income is $300, how do you afford? It's a big challenge. Accessibility to healthcare. Most healthcare facilities are centered in the bigger cities, which is Accra and Kumasi. One of our professors did a research looking at mapping of health facility that's related to essential health care alone, and says that 30% of the population have to travel more than 2 hours to access health care facility. And that's for essential. If you consider cancer care, where only few teaching hospitals offer cancer care, then you have to travel a far longer distance to reach healthcare facility, and makes the situation quite. Now, diagnostic facilities, I mentioned that the cost is a challenge, but even the availability is a big challenge. We have only 18 MRI machines from this graph, as you can see. And 46 CT scan in the whole country. And if I want to compare to you using 1.46 units of CT scan per million population, compared to the United States, you have 40 units of CT scan per million population. So you can imagine, I don't know which percentage difference it is if you want to calculate it, but it shows that people have to wait in line for a longer time. People will delay their disease because diagnostic investigation is going to delay. Pathology labs are very few. Average reporting of pathology report in the government hospital will take like a month. Private facility might give you a week or two, but government facility, because they're overwhelmed with the workload, it might take longer, which is about a month. Diagnosis is going to delay. So this is something to look at. Colonoscopy are few and sparse, and only in the major cities, Accra, Kumasi, and maybe Cape Coast or Takoradi, and there are very few. All the work I want to look at is to really map out colonoscopy access in the country so that we can appreciate it very well. Now, surgical oncological facilities. General surgeons carry out most colorectal-related cases because, as Dr. Jaramat said, we don't have trained colorectal surgeons. I want to be the first person to be trained in that direction with collaboration between the University of Utah, University of Michigan, and Ghana College of Physicians and Surgeons, and University of Minnesota as well to train colorectal surgeons. So studies have shown that surgeries related to colorectal cancer or colorectal disease that are done by highly specialized colorectal surgeons have better outcomes than surgeries done by non-specialized people like general surgeons. So therefore, there's a need for training, which is very, very important. Laparoscopic surgeries are just an unusual. When it comes to laparoscopic colorectal surgery, then it's virtually not there. Mainly availability, trained skills, and I believe that collaboration with the University of Utah will help us in that direction. We want to train more people to go to do laparoscopic colorectal related. This is in terms of availability of radiotherapy, for instance. We have only 3 radiotherapy units in the country, 2 in Accra and 1 in Kofanochi and Kumasi. This is a country of 30 million, has only 3 facilities. And a recent study done by Abascott et al. Mentioned that in 2020, 74% of people with cancer diagnosed and need treatment for radiotherapy did not receive it because overwhelmed machines break down often, long queues, etc. And affordability is a challenge. It shows that we need to really sit down. Research from Ghana is very low, and regarding colorectal cancer is much, much lower. Our contribution to trials is very low, and this is a challenge to show that we need to have more collaboration with people like yourselves to be able to have a look at our cancers are peculiar per race as well, and there might be tumor biology that is very peculiar to the Black race, so that you cannot practice is to look at the research done in high-income countries and extrapolate it and use it in Ghana. You know, the chemotherapy drugs that are designed here, they don't work exactly the same way in a Black race. These are questions. And we need to be part of this research so that we can also now, in terms of strategy, as I mentioned, that awareness of colorectal cancer is very low. Recently, in the month of March, which is the colorectal cancer month, I was involved in a number of awareness, and it showed that the country don't even know that there's cancer called colorectal cancer. Unfortunately, there are very highly educated people who actually so there's another cancer like colorectal cancer. Know our breast, and to a large extent know about cervical cancer, but awareness is not there. And if there's no awareness, how do you institute measures for early screening, for primary prevention, like lifestyle changes and stuff? And now Ghana is moving to the Westerners diet, high processed diet, like what we are eating here. So our race is increasing markedly. We have more increasing obesity because of our diet as well. Our initial diet or high fiber diet is really down, because now the cost of those fibers are quite more than most families could afford. So we are eating polished rice more than we used to do. So our incidence is increasing, and people don't know that they have to reduce these risks and when they don't know that there's a cancer like that, then there's work for us to do. I advocate that the National Health Insurance, in terms of collaboration, go to take on the cost of screening. At least fecal alcohol blood should be taken off, not too expensive, should be taken off by the National Health Insurance. And even colorectal cancer should be identified as a rising cancer concern in the country. And therefore, they should take up, because if people have to buy their own chemotherapeutic drugs, pay for their own radiotherapy, it's going to be a hard challenge for them. Now, regarding, we know that not only surgeons manage cancers, basically, only multidisciplinary team, and more collaboration with the radiation oncology, the medical oncology is very, very important. And participating in multidisciplinary tumor boards are very key. And these studies have shown that a tumor board improves outcome in patient care. And I got a chance to be part of the University of Utah Tumor Board and that whole University of Michigan Tumor Board, and it really made a great impression on me. And Tumor Board gives access to residents to learn how to manage most of these cases as well. They have CT scans and stuff. So we need to improve upon our tumor board in the country. In terms of training, as I said, luckily the Ghana College of Physicians has started this training. I'm the first to undergo this training. Honor slides on me and others. My teachers will to train more people across the country so that we can be able to manage this complex disease much better. And as I mentioned, we need more collaboration to be able to understand our tumor biology better in terms of research. So, in summary, for my first half of my talk, is that colorectal cancer incidence is increasing greatly in the country. Our college has identified this and started the training of highly skilled surgeons for that. But we need to work on how to improve upon early diagnosis and collaboration with Center for Global Surgery and the University of Utah will help us to improve the outlook of patients with colorectal cancer. I have significant acknowledgement. This is a list of my mentors, very great people. Some are working here, right here in the country, and they have made a great impact on me. Their dedication and commitment to my training is very well appreciated. Thank you very much. We have a quote. I can't be an African and talk about something without being an African. Very important that I like so much. It says that if you want to go fast, you go alone. But you want to go very far, we go together. Talk about collaboration, we need to work together to improve upon the outlook of colorectal cancer patients in Ghana. Thank you very much.
How would you, I just wanted to kind of get your thoughts, Dr. Wong, on
I just step out for a phone call in a second, but just to give some context for this, one of the goals that we're hoping to have with Dr. Agbedinu during this visit is not only kind of introducing the clinical care that we provide here, but also really starting to think about collaborations. And I think there's kind of really a really ripe environment for that. At Confinoche, they're very interested in looking for trying to both build the research infrastructure there for their trainees as well. And I'm very interested in that as well. And as Kwabena is very interested in that. And so I think what I was hoping in the second half to do is to just really almost open up the floor and to say, he's identified these gaps, right? And what are some ways that we can potentially address this, in small, short-term, medium-term, long-term goals in terms of collaboration. So I'll just throw something out. For example, we were talking on the way over here that the cancer registry is really based only in Kumasi. And so we only have data for that Kumasi population. So that number is a gross underestimate, right, of the cancer. And is there a way that we can either try to extrapolate that data across the country, do a cross-sectional one-time, data collection? Because I think that understanding the epidemiology and how common this is will help us move the needle at the Ministry of Health. Another thing that Dr. Noriaku, our department chair, has challenged me to kind of think about is what are ways that we can leverage known strategies for improving colorectal cancer awareness in other countries. So for example, Memorial Sloan Kettering has partnered with people in Nigeria to raise awareness there. Can we do something similar, learning from their experience, perhaps even in collaboration with Ensign College, our own resources, or the fact that we have not only our university, but Michigan, Arkansas, Minnesota, and very invested in building colorectal cancer capacity, colorectal surgery capacity in the country. And so just kind of using that as a launching point, I'm going to step off for this call, but I think what we were hoping to kind of gain from this is let's get some energy from people here and see what people think might be good stepping stones or resources we haven't thought about or things like that we can bring to bear. Because that seems like a big problem, right? But at the same time, these are achievable gains that we can chip away, and it's been done before, right? It's been done in other countries. So I apologize, let me step out, but I'll be back in a moment. So
I think it's a great to
implement, say, those surveys that you were talking about, and not just in the very focal manner, like just in your hospital or immediate, but like all over this region. And then you can compare it potentially to the region that hasn't done it. And then it would be a good way to present it to the government to have more funding to implement it wider.
Yeah, that's great. And answer your question, we have the national structure of healthcare system, what we call the Ghana Health Service, which is structured to tertiary, third level of service, to the regional level, to the district level healthcare center. So the structure is there. There's so much burden of infectious disease that cancers are low on their list, and maternal and child care higher in terms of infection, the HIV, TB, and stuff. So, like for cancers, if you come to colorectal cancer, their focus is not so much there at this time. So we need to tell them that it's something to focus on. So in the data to know that this number of people are getting this cancer is something to focus on. So I was talking to one of the directors recently. I did a presentation of colorectal cancer in terms of her CPD. And she was part of the CPD. I was asking me, how can we tell us, okay, then if we do, just like what you are saying, in a particular region, do the study, do the screening, and tell them that this is clearly the number of people who have it in a particular site, then they will pick it up and try to reciprocate in other regions. But we need to give them the data. And that's the challenge. And because research is not supported, my hospital, if you are doing research, you do it yourself. Mm-hmm. Either I manage to find funding from collaborators, or I use my own money to do the research, which is challenging. Mm-hmm. Which is challenging for our collaborators to bring in some of their funding. They are going to have a difficulty. So that I need to tell them a story. I need funding to get the figures.
Go ahead.
Yes, thank you, Kwabena, first of all. One question, I'm wondering how, where would the obstacles be in terms of having long-term and large-scale change in the population? Have there been health campaigns before in Ghana, and what has been the outcome? And if those haven't turned out so well, what obstacles do you think there would be in kind of changing public perspective and behavior?
Campaigns have actually been done in Ghana. For evidence is regarding breast cancer, it's highly done. Breast cancer month of October is a massive campaign. But personally, I feel that in terms of behavioral change, there's still a challenge. Either I was involved in breast cancer advocacy long before I decided to really concentrate on colorectal cancer. And we go out, the recent one in 2022, which I did quite actively. I go out to identify those, we do the awareness, we do the screening, we do the self-clinical breast examination, pick up masses, or those who are not masses, you give them request for mammogram, but they do not come back. And the reasons you get access to them, cost is a challenge. Mammogram facilities are not that many. I think Matt Price did a work recently and presented the last time about mapping of mammography facilities in the country. That I want to do a similar one for colonoscopy facilities. The availability is low, so that the cost is high because it's not so common, and most of them are in the private hands. As I speak now, my own hospital, Kopanochi, does not have a functioning mammogram. You can imagine the second largest teaching hospital does not have a functioning mammogram. It's sad for. So the people have the knowledge, sometimes translating the knowledge to actions to improve their personal health is a challenge. And I think this is difficult. Yeah.
Thank you.
I know they've highlighted specifically in Uganda, similar cervical cancer screenings where they do mobile HPV and pap smears that then they follow up to the positive test, kind of similarly to what you would do with a FIT test. Have you thought about kind of applying a similar method that way? And is that something that do you think?
I think that one is highly feasible, like going to the community and we can easily do the fecal alcohol blood test. Then those who are positive, offer them the colonoscopy for confirmation of what pathology they have. Then we can continue. So it's highly feasible. Mobile clinics are done in terms of outreaches in the country. I've been involved in a lot of surgical outreach, go to the interline and do surgeries and stuff. So this is feasible. We can go to the community, and the chiefs are ready to help. If you give them the evidence that this is very important measure that will improve the health of their population, they are ready to support you, give you the opportunity to talk to the community, screen them easily with the fecal alcohol blood test, and then we can do the colonoscopy as well. It's highly possible, and I'll be ready to collaborate on that.
You said earlier that, and maybe I misunderstood this, but the government insurance doesn't cover screening. Like, what's the process of getting them to cover that? Because I imagine it's probably one of the big, if not the biggest barrier to screening in general, is if they just can't pay for it. Like, what's the process of getting approval for that?
Yes, I think the problem might be to want to really have a good data and make those who make the decision go to convince them how important it is. I think that's the first step. And they are spreading money across various healthcare, and so that they're kind of prioritizing and see which one is possible to support, which one is not. And earlier on, people are talking about, and there was only breast cancer which was covered, treatment was covered. But even that one, screening in terms of mammogram is not covered. You have to pay for it yourself. But if you are diagnosed finally, in terms of chemotherapeutic agent and radiotherapy will be supported in the care. So people spoke about it, and cervical cancer was hooked onto it. So there's work for someone like me to do to convince them with data that this is a cancer worth pay attention to, because in the near future, by 2030, we're going to have an avalanche of cases, and therefore we need to put up the measures. And I think if we're going to convince them, they could add, because I think that screening, I live with the paper-based test should be possible. I think it's possible. Hello.
It's a great presentation. I'm wondering how your partnerships with US-based institutions has helped move this work forward. What have been the benefits of it? What are the main challenges to working with an institution that's in a different country, and kind of your thoughts on that? There's many different collaborations with Companoche and different institutions. Like, what works, what doesn't work when you're working with another institution in a different country?
Okay, I work with Henry Ford system. Personally, we are doing some breast research for a number of years now. And I think, great, because the support is there in terms of providing us with the things we need to care for the patient. They give us facilities like in breast, cord biopsy needles are added to support the patient, because as I said, you have to pay for your own biopsy test, and therefore those supports are there. And in terms of resources, when I need some, in terms of academic resources, access to literature and stuff, we get it. In terms of training, they are able to organize some training in terms of grant writing and stuff. So those aspects are good. The challenge, if I must say, is that sometimes because the Europeans go for the grants because they have something in mind, and some of them might not be exactly what we really need down there, which is a challenge. So if it becomes a grant up approach where we get ideas and say, okay, this is something you should consider, and you want to work with the NIH and staff to get a support, it might be quite something. Because in my breast, I said that no, we need to have mammogram as a support if you want to really make a greater impact in our breast study, because patients cannot afford. So we need something that we can work on to get access to. If it's a mobile mammogram machine, so that we go for one region to as a support from the grant to help our people diagnose breast cancer early, and we need to look at that.
So in the short term, so in the next year, it seems to be that a few things could be feasible, like doing a survey of primary care doctors to know what their knowledge base is, There's something called knowledge, attitudes, and practices surveys to kind of assess that. Like that's something that's doable to gather information from the first point of contact. Maybe worthwhile to even do that with the general surgeons or the oncologists or the radiation oncologists as well. One would imagine doing things like, as you mentioned, kind of mapping the accessibility of the colonoscopy services. You know, how many of them are in private facilities where you have to pay? How many of them are in public facilities where you have to pay? And what is the access around that? I think understanding a lot of those, I would imagine, could be done in the next 1 to 2 years. As you mentioned, our group led by Dr. Price, in back there, it surveyed, I think, some 350 facilities across the country for breast and cervical cancer care and access to the diagnostics and treatment available for those particular cancers. So we've kind of, our collaboration has done that for those cancers. So we could feasibly work on similar questions. And maybe you'll have some data there to then take to advocate for, you know, where would you add the next, you know, colorectal surgeon or the next, you know, medical oncology specialist, because maybe you have a surgeon here and a radiation therapy person there, an oncologist there, and the person can't, and one person can't access all three of them, and they need all three of them. So, you know, that seems plausible to do. I think things like setting up a multidisciplinary treatment board is a little bit more complicated, because until you have buy-in from all these different specialists that this is a problem and if this is something that needs to be done, you probably can't set something like that up. I would think. So it seems like the first step is really sort of understanding what people think, what people know, what is the current sort of status of access, and to go there. And then you can think about, like, how would you study? What would you implement? How would you compare changes in screening paradigms? And who's to say, you know, the screening guidelines, you know, 45 years and above to do colonoscopy, all those things, based on data from the US and Europe. Like, how do we know that data is applicable in Ghana? You know, the diet is different, the genetics are different, biology is different. I have no idea. So who's to say it should be age 45? Maybe it should be age 30. I don't know. But it seems that we should probably start with an understanding of what's happening first, before diving into what are the interventions we would want to make. Thoughts from the audience? Dr. Bryce, thoughts?
Yeah, it's interesting, you know, as we presented some of the information about the entire country to the Ministry of Health and Ghana Health Services, one of them, I can't remember if it was the Vice Minister or the Director of Ghana Health Services, said, well, this is all great. We know the problems. What are we going to do to fix it? And I think that's some of the things that is of interest to us as well. That, you know, getting the information is important about where the challenges are. But I think it's also important to realize the things that are already there, as Sudha was mentioning. You know, if we identify the things that are available, and how can we, you know, cost effectively expand those services to areas that can be better? Can we match services with and equipment with people and things in a cost-effective manner that can really help the population? And so I was excited hearing your ideas that sounded like, you know, what can you implement, as well as, you know, study the problem, but in the process, rather than waiting just for understanding the problem more, because we've been understanding the problem for many years. What can we do to implement it? And, you know, implementing a screening with fecal blood testing in a way that has to be ethically looked at. Can you take care of all the people that you identify that come in with that? And so how do you build the ability of a screening program at the same time you're building the ability to treat and care for the program? And again, biting off a small chunk, can't do that for the entire country for one time, but can you do something like that, specifically in Kumasi, as a pilot? They're going to be seen to how can we grow that throughout the country. So that's kind of what, and I think that's what's exciting about having you come here. This is an implementation of, increasing the knowledge of the colorectal surgeons and then engaging them in terms of their ideas of what could really happen. And it's really, as many of the people in Ghana have told us, look, the solutions are going to come from us in Ghana, not from you guys. And I truly believe that. Just listening to you talk got me excited about some of the ideas you're thinking about implementing that could be studied as well. So rather than just studying the problem, studying what you implement.
One, on a tangent, kind of just thinking outside the box. So there's a recent paper, this in the last week, I don't know if it's JAMA or Lancet. I can't remember. But where there's a new blood test, a peripheral blood test
Liquid biopsies.
to detect, I think, cancer DNA, and with a near 100% accuracy in detecting colorectal cancer, and less accurate detection of adenoma, so pre-malignancies. But you wonder if, are there, in this now post-COVID era, where we're really thinking about diagnostics totally differently, are there opportunities to think about diagnostics and screening? Because let's say you do a fecal occult blood test, right? That's a really inaccurate test. And then you're not going to do colonoscopies on all of them because you only have one colonoscope for the hospital, right? So you still need another thing in between. Maybe that's a physical exam, maybe it's a digital rectal exam. But a lot of colon cancers aren't low enough to be able to be detected by physical exam. And so, there's still a population there that may be worth studying in some other manner. And maybe there's an opportunity to think about, something completely innovatively to say, is there a low cost diagnostic test that could be applied that wouldn't, maybe wouldn't be the standard of care necessarily in the US, although this paper was arguing that it should be, it's equivalent to the FIT test, which is actually has pretty good data. Maybe that should be the primary test in lower resource settings, that where you can really be much more specific in capturing only the ones that are most likely to have cancer, instead of 1,000 false positives. And then, not doing 1,000 additional colonoscopies or, additional operations. You can't diagnose them accurately. So just other thoughts to kind of, they're not immediately applicable, but it's just important for us to not also fall into the trap of this is the standard in the US. This is a quote unquote national or international standard set mostly by high income countries, to say, well, that should be the standard. Who's to say that's the standard? Just always rooting for the underdog here in the corner, but it's important to recognize our own biases and our own echo chambers in how we think about these problems and how we think about solving them.
Yeah.
Questions, thoughts, comments? Do you guys have class at 1? Okay, all right. Anybody online? Comments, questions? Thank you all for coming.
Thank you.
Thank you.